All right. Hello, everybody. Thank you for showing up. I'm Lily Williams. I will be leading the new project pain evaluation. Yes, I did already say that, but this is for the recording. And so over summer, I took BMed 450. And for reference, A, I want to go into med school after this and go into obstetrics and gynecology. And B, BMed 450 is about women's and maternal health. And it's officially about women's and maternal health, but the professor Della Ripa goes into a lot more than that and sheds a lot of light on health disparities, especially within the medical field and medical devices, how medical devices impact, exacerbate, and can help or make it worse. So one of the things that we talked a lot about was that when a patient goes in, if they are female or not white, essentially, their pain gets treated very differently than someone who is white and or male. And that has a lot to do with how the patient's outcome will happen later on in the process. Because whenever a minority or a woman goes in, she might downplay her pain or she might not. And then the doctor will then downplay it more, and something that should have gotten treatment is no longer getting treatment. And some cases of this are Kira Johnson, who was a Black woman who had just given birth and she had a hemorrhage, and she needed a scan to see the fluid like right then and there to get that treated and dealt with, but they didn't provide any sorts of scans to even check on it until she was basically dead, at which point she died. And then this has also happened to another white woman who she had a child and had pains, and she had what's called HELP syndrome. And she was saying that she was in pain, and she eventually died because they didn't check on it again, not even check to see if anything's happening until the last possible minute, and basically after that minute, so she died. And what studies have found is that yes, these differences do exist. Minorities, women, people of color receive treatment at a much different rate, a much lower rate than their male white counterparts. And secondly, another study has found that standardizing pain procedures and how pain is evaluated can reduce these differences. So this is what my project is planning to tackle. These smiley faces you are told to look at and say where you are whenever a doctor asks what your pain is. And this started roughly in the 90s, and this specific scale, the Wong-Baker faces, was developed for children. It was to help children have an easier way of communicating their pain, because it is something you have to be taught. However, it is very subjective. Different people, especially as I grew up, respond to pain differently. Cultural influences can affect how you communicate your pain. Gender differences. Some studies have found that while women actually advocate the same degree as men for their pain and pain treatment, they still get less treatment. So it's not in how much they advocate, it's in how they are advocating and how the doctor is responding to that. And so I would like to replace this and the 1 to 10 scale essentially, and make it a standardized, objective, comprehensive chart or method that is appropriate for many cultural backgrounds and ages. And the overarching goal is not necessarily to just make a new chart. It is to facilitate communication of pain between patients and healthcare providers, and to make it so that the healthcare provider can ultimately empathize and respond appropriately to that pain. And the very general process of how this is going to go is research, design, repeat. Research largely entailing lots of surveys, interviews, talking to people. This will be a very phone call, email dense project, unfortunately. I don't like phone calls either, but it's good practice. And ultimately, of hopefully getting a final design. So this is kind of, this is a little dense. It's so that when the slide goes up, it's just kind of there for people to see. For fall 2020, this is also a little rough since we only have 5 more weeks, but 5-ish, but we want to complete a lit review, figure out why the pain chart is the way it is, how it started, how it's used, and get a very in-depth understanding of the procedure of dealing with pain treatment. We want to contact local doctors in that process, and nurses, and DOs, MDs, et cetera, anyone we can get in touch with, which can be very difficult, especially during COVID. I would say even, personal practitioners, if they're willing to speak to us, anyone who is willing to speak with us, on campus doctors. This might even include some of the ethnic study professors on campus, because that is also one of the things that led me to this project. Was I took an ethnic studies course over summer, granted for GE, but I absolutely loved the class. So here we are. And then draft and edit initial surveys. And these will be like trying to get an idea of how people respond to the Wong-Baker chart as it stands, like providing scenarios and saying, how would you rank your pain in this situation that most people have hopefully had? Or what kind of pain level would you associate with like a 10? Like, is this stub your toe, or is this I'm giving birth? It's probably, or like, would that be beyond, where would you put your pain on this chart as it stands? And try to see kind of what the variability is. And then this next step would be kind of have it ready to distribute the following quarter at the end of the quarter. And this would have to include seeing what Cal Poly's expectations are for research. I'm not quite sure where this stands on that. We might have to get in contact with the Cal Poly IRB, the review board. Excuse me. And very roughly, again, this is a new project. The hope is it doesn't run on too long, but as it stands, over winter, we would want to compile data from the survey, analyze it, attach certain numbers to certain words, get, standard deviation mean, et cetera, and draft an outline of initial design of our communication product. The next thing would be to kind of do like focus groups and just see what doctors, nurses think of the idea and concept. People who are willing to work with us. Oh my gosh, I have a tickle, I'm sorry. And then identify, like, as we're going through this, maybe start identifying where we want it to go afterwards. Like, a lot of MDC projects apply to competitions. I don't think this is where this would go, but getting an idea of that end goal of where does it go? We know what we want it to do, but what do we do then? And then I also would like to take it and apply it to a very specific case study example, where, for example, a woman comes in with abdominal pain. What would that process look like? Oh my gosh, I don't have water. And that would continue into winter, redesigning, re-evaluating. And then there would be an ultimate final, like, redistributing it in the same way as the Wong-Baker to see how people would rate their pain and getting that idea on a much larger scale. This will be a very heavy, one second, I'm gonna, I have a nasty tickle in my throat. I am so sorry, guys. And it's still there. So if I have to, anyway, it will probably require some Excel, MATLAB data analysis. These are things that I'm more than willing to work on with people who are newer or less experienced. I am also learning. I'm going to be back. I'm getting a drink of water. I'm sorry. I hope everyone enjoyed their intermission. I'm willing to work with people on that. For those of you who have taken BMed 310, I think it's a pretty solid foundation to start with for this. Oh my gosh. And of course, making calls, writing emails, get comfy with it. You'll have to for any job anyway. This is a good place to start. Research, as I mentioned, a lot of drafting surveys, making sure that they're not that they're appropriate and they get the answers that we don't necessarily want, but that give us the data we need. It will require some graphic design. I'm not entirely sure to what extent yet, but assuming that we do redesign the chart to a degree, it will require appropriate icons, simplistic designs, especially so that it's accessible. And any cultural or, you know, linguistic knowledge you can bring to the table would be absolutely phenomenal, because I would like this to be accessible to lots of people, because right now the current situation is not, especially in communicating appropriately. And again, so for the team, anyone who wants to apply, please apply. All experiences are welcome. And by apply, I mean sign up, fill out the thing that'll go out. But all experience levels are welcome. It's not a particularly technically difficult project. This is kind of our, we need to have something that will absolutely function over Zoom project. And that is the plan for the next 3 quarters, is this will be able to be done completely virtually. So all experiences are welcome. I think it's a really important thing to work on. Please apply. It'll be great for learning how to call people and email people and make sure your grammar is good. Those tech writing classes are important. The goals are for the team are communication and teamwork, like learning how to work with people. If conflict comes up, knowing how to navigate that, understanding the importance of ethics and design, which is kind of brushed on in a few of your classes probably, but again, I think is very important, because not everyone is affected equally by these products. A lot of times what happens is a lot of work and effort goes into something and making it affordable. It gets tested on a low income population, either within the States or outside, and that population will never see it again, because they can't, it is now no longer affordable because of the materials, the manufacturing, and the approval process all require money. And organizationally, I expect to have kind of subgroups, and I'm kind of undecided on how to set those up. Maybe having constant sets of even numbers of people, depending on how many show up, who the tasks they are assigned roll with how they complete things. Initially, it will probably be broken down into like writing emails, calling certain people, like one will write emails, one will call people. And one will be doing like lit review, is just kind of an example. And then these are also pretty loose. I would, eventually I would think that, especially at the end of the quarter, we would expect one, as a total, like 3 to 7 hours a week of your time. This really depends on how many people are a part of the group, and it also depends on where we're at in the process. I don't actually expect it to be 7 hours a week entirely yet, but I'm putting there generously so that no one's surprised if it happens. Meeting time, I'm thinking, like everyone else has kind of said, like a check-in meeting during the week and then an actual work meeting during the week, or maybe those will be combined. And then time outside the meeting will be about 3 to 4 hours to get stuff done, so that it's not all done in one day, and so that we can also distribute the work. And then this will, as has been mentioned, probably increase at the end of each quarter, because we are submitting summaries / presenting our progress to the board of officers. And I put asterisks on the last thing because I kind of want to continue as much of this as possible over winter break, but I recognize that people have very different schedules, very different time commitment levels during the breaks, and that might be very much a whoever can afford the time, please afford the time. But the expectation will be, we'll work that out as it comes closer. And any questions? chat.